This eye condition is a serious emergency, and few people outside of the eye care field will even hear about it until it happens to them. Few people even know that they could be at risk. So listen closely and share with friends, because you could just save someone's vision. A normal functioning eye has fluid flowing through the front. It starts here and goes between the lens and the iris, the colored part. It moves forward through the pupil and exits in this little angle here between the front of the iris and the back of the cornea. It's this narrow little angle, and there are a few things regarding eye anatomy, certain medications or certain activities that can cause this iris to start to bow forward and close off this angle. When that happens, fluid gets stuck between the lens and the iris, and then the iris bows backward and sticks against the lens around where the pupil is located. So the fluid keeps building up and up and up in this small little area, and the angle gets more and more closed off. This causes the eye pressure to spike. It's usually between 11 and 21, but it can spike all the way up to 60 or even higher, and it causes really quick damage to the optic nerve that can cause vision loss in the periphery of your vision, and then the longer this is going on, it can also affect central vision and can even lead to total blindness of an eye. It's important to get it treated within a few hours, otherwise vision loss can be imminent. This is acute angle closure glaucoma. If any of these apply to you, you may be at increased risk of acute angle closure glaucoma. Increased age, if you're of East Asian descent, if you're a female, if you have hyperopia or farsightedness, or if you have a positive family history. All of these things have in common an eye that has an anatomy that's typically smaller or more crowded, because that can crowd the angle. And that would include the increased age, because as a cataract develops in the lens becomes a little bit larger and can make the space in the eye a little bit more crowded. Now, it's important to remember that even if you don't fit in one of these categories, you could still have acute angle closure glaucoma. I've seen it outside of these categories. A risk factor simply means that you're more likely to develop something, but you could have everything that's a risk factor and not develop this issue, or none of them and still develop this issue. Sometimes angle closure is even onset by developmental abnormalities or certain medications, so it's really important for everybody to know about this. The best way to know you're at risk is to see your eye doctor. There's a certain test that they can do called gonioscopy, where they use a special lens to look at the angle of the eye to see whether it's open or closed. The angle can also be evaluated in different ways, but they're more of estimations, they're not as accurate, and gonioscopy is the true way to find out. But your doctor should be able to tell you if you appear to be at risk and if a gonioscopy test is necessary. Have you ever gone to an appointment and your doctor decided not to dilate your eyes because they thought you were at risk? Other risk factors that could cause acute angle closure are dilation eye drops, systemic anticholinergic medications, accommodation or reading basically, and dim illumination. There are also other risk factors that can cause angle crowding, and if you fall into one of these categories, you may be already following up with your eye doctor pretty regularly and may be aware of these symptoms, but in some cases people aren't, so let's go over these. If you've had cataract surgery and the lens that was implanted was put between the iris and the lens, this is called an anterior chamber intraocular lens. If you take a drug called topiramate or a sulfonamide drug, especially if it's within the first 2 weeks of starting medication, or you've had a recent increase in your dosage, abnormal iris configuration or plateau iris, developmental abnormalities of the eye, your doctor's diagnosed you with peripheral anterior synechiae, which would be a result of uveitis or inflammation within the eye. If you have membranes that are obstructing the angle. It's very unusual to have acute angle closure occur in both eyes at the same time, so we're typically talking about unilateral issues, which could be a frontal headache, severe eye pain, blurry vision, nausea, vomiting, redness of the eye, halos or rings around lights, and a mid-dilated pupil. It's kind of stuck halfway between dilated and constricted. And then if this had been going on for a while, a few hours or more, you might already have some loss of peripheral vision, and the longer it goes on, it can cause loss of central vision as well. There are people out there who may experience a more mild version of these symptoms, and it's kind of a warning sign that acute angle closure could happen to them, particularly halos or rings around lights. And this often happens after one of those risk factors we discussed earlier, like reading or being in dim illumination. So if you've experienced these symptoms on a more minor level, you may have a narrow angle that's at risk of closure and should seek out your doctor to take a look to make sure this doesn't happen to you, because there are ways to prevent an attack. So what should you do if these symptoms happen to you? Well, you should call your doctor day, night, or weekend and start heading there while you're getting them on the phone, because like I was saying, this causes permanent damage to the vision, and this damage can occur very quickly, even within a few hours. It's important to know what to expect that will happen with your eye care provider so you go prepared. They'll ask you about your medical history and use of medications, because like we were discussing, some of these can actually be risk factors for acute angle closure. They'll do a slit lamp examination of the eye where they evaluate it with a light. They'll do gonioscopy to look at that angle, and they may use a compression technique to try to end the acute angle closure attack. They'll measure your eye pressure. They'll try to get a look at the retina, particularly the optic nerve, to note the initial health of it. And in some cases, they may do an ultrasound of some kind, especially if the cornea is really blurry, which can happen because it often begins to swell, making our view of the internal structures of the eye very difficult or sometimes impossible. In your visit with your doctor, you should also expect very prompt treatment of the condition. The whole goal of the treatment is going to be to increase the outflow of fluid and try to decrease the amount of fluid that is being produced by the eye. And this would be done with a whole collection of glaucoma eye drop medications and also an oral carbonic anhydrase inhibitor. Sometimes an IV will be used to put in an osmotic agent. The whole goal is to suck the fluid away from the eye with these medications. Mannitol is an example of this, though there are some cases where this is contraindicated and can cause a lot of complications, and this is where knowing your health history and sharing that with the provider is of the utmost importance. Compression gonioscopy that we talked about earlier may be used to break an attack. A topical steroid may be helpful. You'd expect your doctor to be checking the eye pressure periodically over the course of at least an hour, often more, until things seem to be fairly under control. And then a laser peripheral iridotomy will be performed within 1 to 5 days after the initial attack. This is where a laser is used to make a small hole in the iris so that there's an extra pathway of outflow for this fluid so this doesn't happen again. An LPI or surgical iridectomy will be recommended within the first 5 days of having a glaucoma attack. And of course, the name of the game is prevention. The anatomy between the eyes is very similar, so the doctor will likely recommend that you have an LPI in the other eye. There are a few rare cases I could think of where it may not be necessary or recommended, but that'll be up to your doctor and they'll discuss those reasons with you. You would also expect the doctor to evaluate the health of the optic nerve with a retinal exam. Once it is safe to dilate the eye, they will likely do so, view the rest of the retina. They'll also likely take visual field tests to have a baseline to see if there is any visual field loss that occurred with the initial attack, and also to have information on the visual field of the other eye, checking for any other signs of glaucoma, and then maybe monitoring over time if they feel that you are at risk for continued peripheral vision or central vision loss. Your doctor will be likely to monitor you closely at first and decreasing the frequency of appointments over time until they are sure everything is stable and under control. When it comes to health or eye health in general, prevention is always important. So if you are at risk or if you've had an acute angle closure attack in one eye, talk to your doctor about an LPI prophylactically for the other eye to prevent an attack there. Ask your eye doctor about your angles and gonioscopy, especially if they consider your angles to be narrow or at risk. It never hurts to ask, and be sure to continue to see them regularly. Don't forget to tell a friend and subscribe for more information about eye and vision health. Thanks for watching, and I hope to see you next time.